Right, I've been given the green signal to start the day now. There will be more people joining as we go along, so that's absolutely fine. Um, Welcome everybody. I'm Mahesh Odiyoor. I'm a consultant psychiatrist and the strategic clinical director for learning disability, neurodevelopmental disorders, and acquired brain injury services in Cheshire and Wirral Partnership NHS Foundation Trust. I'm also the clinical lead and deputy chair of the Northwest Operational Delivery Network, and we'll be talking about quite a number of these things as we go along through the rest of the morning session. It's my immense pleasure to welcome you all, and thank you very much for taking the time to join us today to talk about the decision support tool for physical health, but also explore and think through some of the challenges that people with intellectual disabilities as well as neurodevelopmental disorders face in terms of their physical health needs, not just the physical health needs, but also accessing services. And the whole morning's conversation today is to say, how do we understand that challenge better? How can we stratify those needs better? And then how can we meet the needs of people who have complex needs better? So that's the focus of today's conversation. There are some there are some interesting talks, but also people who have explored the concept of the complex physical health needs from various angles, discussing and presenting today. So hopefully that will lead to more conversations and development of better services across the network as well as across the country. So I have also been asked to mention about a couple of general housekeeping. So usually I would have been talking about the fire exits and toilets and other things. So I don't need to do that today. So the general housekeeping are more technical today. So in terms of subtitles, if people wish to have subtitles, some of us may struggle to listen in, or if you want to have subtitles to read through as we speak along, you can turn on your subtitles. So when you go on the top bar where it says more, if you click on that, there is a section called language and speech. And in that you can click on, and then you can click on the turn on live caption. If you do that, the live caption will come on for you on your screen, which means that you may be able to follow the conversations better. The next one is the question and answer. Again, on the top bar, there is next to the chat section, there is a section called Q&A. So if you click on that, you can send your questions in, and they will be anonymous. And what we'll try to do is answer them either as we go along. So Rosalyn, who is managing all of this in the background, will be trying to respond to that as quickly as possible. If not, we will, if there are specific questions to the speakers, we can always get the speakers to either answer them, or we can find the answers and then get back later on as well. The event is recorded. And I'm hoping that everybody is okay with that. The event will be recorded, and the slides and the recording will be sent out after the event finishes today. So it will either be later today or early next week that it will be sent through. So those are the general housekeeping for today. I hope you're all comfortable. You have had your morning breakfast, cups of teas, and hope you're ready for exciting morning session on the decision support tool for physical health. So it's my immense pleasure now to introduce the next speaker. It's Professor Sujeet Jaydeokar. He is the chair of CANDID, which is Center for Autism, Neurodevelopmental Disorders and Intellectual Disability. He's also a consultant psychiatrist and clinical director for neurodevelopmental disorders and acquired brain injury services in CWP. He has a number of other hats, including visiting professor at Chester University, and basically our go-to person for anything to do with technical stuff, research stuff, and other things in CWP and beyond. So it's my immense pleasure to welcome Sujeet to talk about the Re-Stratification and the development of the decision support tool for physical health. Sujeet, over to you.
Thanks. So on the technological side, I might have done something and stopped sharing. So I'll wait for Rosalyn to put the sharing back. If not, I will try to bring the slides up. as well. But yes, so I'm Sujeet Jaydeokar, so I'm consultant psychiatrist, and I have a lot of interest in the health inequalities. So we have been doing quite a bit of work around health inequalities and how we deal with that, et cetera, et cetera. And we started with this project a good few years ago, and we have been systematically working on. And I think kind of it's great pleasure that having this opportunity to share as to what we are doing in terms of using stratification-based approach. And we are here all to actually kind of discuss and think about how we sort of reduce avoidable deaths in people with intellectual disability going forward in autistic population as well. So I'm going to give a bit of background in terms of how we came about this idea, why we came about this idea, and what we have done in terms of developing the tool. And then as we go along during the mornings, there will be more presentations around the use of tool and what we have learned so far. So what were we trying to address here? So and this is like, you all know this, so I don't have to go into details, but just as a context, we know that people with intellectual disability die much younger than the general population, and there is an even higher level of morbidity compared to the general population, and that has led to a big health inequalities gap. So I mean, those are the three key points here, isn't it? In a way, and I think we talk about the gap of 20 to 23 years for people with intellectual disability, but even those without intellectual disability, autistic population, the gap is around 17 years. And there was a recent news story in the paper as well about the autistic young people. So that's what we are trying to address here. Next. Um, so in terms of what has been happening, so we all know that NHS England set up the LADER program. It has changed hands, and it's with King's College London now. And the last report came in 2021. I understand there is a next report due, and we are fortunate that we have Professor Umesh later on talking about the LADER program as well. But it has been going on since 2015, and there have been 6 annual LADER reports so far with number of recommendations. So we have learned quite a lot in terms of underlying conditions. We have learned in terms of systemic issues, but we still know that people with intellectual disability continue to die much younger, and there is a big health inequalities gap. So this is what we are trying to address. The reports had also highlighted, these are the previous reports, like delay in diagnosis and treating illness, problem with organizational systems and processes, gaps in service provision, all contributing to avoidable deaths. There were some recommendations like we need to address system level issues through care pathways, standard operating procedures, staff training was important. We have Oliver McGowan training now being rolled out nationally. Need for care coordination, need for communication related issues, addressing communication related issues, addressing the issues around DNA CPR. We saw that during the COVID crisis as well, the inappropriate use of DNA CPR. And I think we do need to do work recognizing early signs of deterioration. So there are all those recommendations there, and we were wondering how do we go about that. So before we go on to our approach, just want to give an example. So this is Alan. Obviously, the name has been changed. Someone with young man with severe learning disability and autism. This is what we are trying to address in a way in terms of health inequalities gap. A person with communication difficulties recently moved to a new provider accommodation, having difficulties, carers struggling, escalation of challenging behavior was there. But also this is a real life example, what the a team noticed that carers had limited information about physical health needs. But when we looked at the electronic patient record, records, history of bowel problems, epilepsy, high blood pressure, etc., etc. So, number of issues that were actually going on, but carers did not use any health monitoring or observation tool. He had very limited GP reviews due to access issues around challenging behavior, etc. So I want you to keep this example in mind, and it is nothing new, isn't it? I think those who are practicing in community learning disability services or in primary care or in as LD liaison nurses in hospitals, you have seen this as a common presentation, but keep this in mind. So what we wanted to do, we wanted to take population health management approach. And I think this is all about equity of outcomes. We can have sort of equality in terms of the interventions that could be provided, but that doesn't lead to equity in terms of outcome. If we want to achieve equity in terms of outcome, we have to take different approaches to management. And I think that's the key part that we need to actually think about. It's not about that everyone have access. I think the quality and nature of that access is also important. In fact, more important if you want to have uniformity or equity in terms of the outcomes that we want to achieve. So the population health, it is about actually looking at the outcomes for a group of individual or the whole population cohort that we are looking for. So in this case, we are looking for people with intellectual disability as a population cohort. We want to achieve equity of outcomes. But if you want to achieve that equity of outcomes, we do need to have actually a stratification process so that actually there will be a needs-based approach to achieving those outcomes. And this is where the population health management principles come in place. So population health management looks at 3 levels. And this is like, I'm not a public health consultant. This is like my understanding, my basic understanding of how these things work. So you're looking at a macro level, meso level, and micro level. So 3 levels. So macro level is looking at the whole population in a way. And strategies that are applicable to the whole population. So I'm going to use the example of COVID. I think kind of, having a vaccination program for the whole population is a macro level strategy to reduce actually the impact of COVID and sort of deaths related to COVID. But at meso level, within that population also, we have to use different strategies for different population cohort. So using population segmentation or stratification of risk, i.e. there are people who are more vulnerable to COVID than others. And then the measures come that early vaccination for them, shielding for them, etc., etc. So, we all know that. Actually, we have experienced it over the last 3 years. Okay, I have just been said that slides are not moving on. They're moving on my computer. Rosalyn, are you able to actually control the slides? Oh, okay. Sorry. So are you seeing the population health management slide now? Yeah. So at micro level, then we are looking at strategies or interventions that is the disease level management at individual level. So where the hospitalizations comes in, use of like oxygen and all that we saw in COVID. So that's actually the disease management. So population health management works at all those different levels. So what should we be doing at it?
Also, you have to click the slides. You can't move it. You need to tell the
next slide. Okay. Okay. So I have just been said to tell Rosalyn to move the slide. So I'm on the right slide now. What should we be doing at each of these levels? So we need at public health level strategies to reduce morbidity and mortality. We need at primary and secondary care level, that is meso level, strategies to ensure proactive management of underlying condition, including managing system level issues. A lot of those issues were identified with LEADER program. And then we require individual specific disease management strategies for individuals within the population. So this is where I'm talking about the population in terms of those with learning disabilities. Next slide. Okay. If the slide doesn't change, just let me know. So this is where we are looking at so this is where we have looked at actually the predictive modeling. So when we look at the population health management, the predictive modeling is the important part. So predictive modeling is the cornerstone of stratification process and population health management. And what we mean by that is that we need to identify people or predict who are going to be at the most risk. And in a way, it is dividing the population into sort of a lower risk, moderate risk, and high risk, or kind of, that can be a change according to the condition that we are looking at and circumstances we are looking at. But for example, I think you're looking at predictive modeling and kind of assigning the person based on the stratification within the care management pyramid. Some people might need only health education and promotion. Some people who are with moderate risk might require additional strategies like coaching, lifestyle management, and some might require intensive case or disease management. So for example, if you're looking at obesity, some might benefit by health education, etc. Some might benefit by a bit more management approach, and others might actually benefit by specific medical management strategies. And I think if you apply that to, let's say, physical health in people with intellectual disability, it might be that kind of like those with everyone will benefit by having annual health checks and health action plan. But on top of that, some might require health coordination. And on top of that, some might require intensive case management. But how do we decide who should be receiving what? And this is where our approach comes in. So what we wanted to do, we wanted to look at stratification based approach, take a population health management stratification-based approach for avoidable deaths in people with intellectual disability. So we wanted to develop a tool that can proactively identify people with intellectual disability who are at increased risk of dying prematurely, and then wanted to develop a framework around that. So we took a quite systematic approach in the development of it. It wasn't like kind of me, Mahesh, or Dani sitting in a room and coming up with this. Quite a few people were involved. Some of you are here in the audience as well. But we went through an extensive exercise of identifications of factors using focus group. We had 5 focus groups for that, and these were made up of actually people working not just in CLDTs, multidisciplinary, but working with people with intellectual disability in other healthcare settings as well, including acute hospital and primary care, etc., etc. We also carried out a review of literature, scoping review of literature, to identify all the factors that are known through literature, and this included the LEADER program as well. And then we worked on synthesizing those factors to identify core factors that we should be considering for this stratification tool. We had focus group of multiple professionals then to actually rate factors for their relative significance, because some are quite critical factors, Some are more contributory factors, so we wanted to do the analysis of that. We did the weighted scores for those factors based on their relevance and importance, and then that's how the dynamics of decision support tool for physical health came about, and then we started piloting that. As part of the process, we used Delphi groups quite a lot. We had face-to-face Delphi groups. This was just before COVID, actually, so we could meet at the time to do some face-to-face Delphi groups. And the whole idea behind Delphi group was that we had consensus. So Delphi group is a quite a good research methodology where actually you bring experts together. There are questions asked. Everyone has an opinion, then there is a discussion, and idea is that through the discussion one comes to a consensus statement. So that's what the process that we actually used. So the tool has two parts. First part is factors impacting health outcomes, and second part is about underlying health outcomes, and it gives a RAG rating, red, amber, green rating, depending on relative risk of avoidable death. And I think that's the important word. Everyone with intellectual disability is at higher risk of avoidable death compared to general population. What we are looking at here is that within the population of intellectual disability, who are at imminent risk, who are at high risk, and who are at lower risk within that population. So it's a relative risk in a way looking at it. It's not a risk assessment tool. So I'm not going to go through the tool now because Danny is going to cover some of those things a bit later on. But you're welcome to visit the website, which is candid.nhs.uk/DST Physical Health, and you will be able to see the tool there. As I said, three ratings: who are at imminent risk, who are at high risk, and who will be at risk if there were no reasonable adjustment, annual health checks, and health action plans, because we know everyone with learning disability requires those things to prevent avoidable deaths. And then based on that, we have developed a framework of a response. So idea is that anyone who is green should have reasonable adjustment, communication needs, etc. We need to ensure those. We need to make sure they have annual health checks, health passport. But for ambers or those who are at high risk, in addition to that, we want them to have healthcare coordination. We want person-centered healthcare plans, a regular review, specialized joint clinics, etc., those sort of approaches. And then, in addition to that, anyone who is red should have review of their care and treatment with multi-agency response. So that's the way kind of we have conceptualized the two. So the Alan story, going back to Alan's story. So Alan had, as I mentioned, number of problems there. He was rated as amber. He wasn't at imminent risk, but if not something wasn't done, he's the kind of like candidate for that premature mortality, avoidable death type scenario. So it necessitated care coordination, multi-agency working, discussion with the GP to kind of like, work towards to get the access to the records, etc., etc. The DST Physical Health tool allowed us to identify specific targeted areas for intervention. So his epilepsy kind of like was sorted out through referral to neurology services, medications were adjusted. So it took a multi-professional collaborative approach to that. We started desensitization work so that he could actually allow regular blood checks, blood pressure checks, etc., etc. Develop the program with short visit to GP surgery so that he can have access to the kind of like physical health examination. So systematically, it was a long process, but it was a systematic work that allowed then us to reduce the risk of preventable death in Alan's case. And I think that included everything, including training, etc., etc., for those individuals. Right. So what does the tool allow us to do? It is very quick to use. It can be used either in primary care or in community learning disability. It does take the potential risk factors into account. It's very objective, so yes and no questions, a lot of it. And it focuses on interventions at individual as well as at system level. It does allow development of of innovative solutions, and we think that actually when we look at a population level data, and I think Rosalyn will present some of it after me, it allows actually thinking about our commissioning intentions, in the sense what we should be thinking about within the region, within the services. It can be used by any health professionals working with people with learning disability, intellectual disability. Like I said, primary or secondary care, it is based on individual's current presentation. We are not looking at it being dynamic in the sense changes, because a lot of those things are static, but it needs to give us a framework that he's a person or she's a person that needs that regular monitoring of underlying conditions. We have done quite a bit of work. We have done piloting. We have rolled it out actually. So there has been kind of looking at clinical utility in primary and secondary care, and it has been received positively. It does require training to go with it, especially until people get used to the scoring and how to kind of like, go about. We kind of like found that actually in GP care, it worked much better than in CLDTs, because I think GPs were doing it quite objectively as yes and no. And then we developed guidelines for use in primary and secondary care. There is development of online training material, videos, etc. We have for our service, we have done standard operating procedures, but obviously SOPs needs to be done by individual kind of organizations based on the guidelines. And then we are working with the ODN on developing kind of more wider pathways. The tool has been used in a number of NHS organizations, and I think a couple of them are going to present their pilots as well. The whole kind of project was supported by NHS England, so it's part of the NHS England practice example. Mahesh will talk more about the ODN and the work happening through that. More information, etc., is available for people to look at on the website. It's all free. It's all easily available. So that's a brief overview of DST Physical Health. Thank you. So I think in terms of the presentation, the next one is going to be Rosalyn. Rosalyn is our research assistant who did quite a bit of work with us on data analysis and validation, and she's going to share some of her findings. Rosalyn, are you okay to control the slides and all that?
Hi, Sujeet. Yes, thank you.
Okay. Okay.
So,
thank you.
So yeah, hello, I'm Rosalyn. I've been a research assistant at Candid for the past year now. And my main role has been doing some data analysis on this tool. I'm going to give a very quick overview and some analysis I've been doing, mainly focused on one, which I've been doing. So yeah, firstly, I'm going to be talking about the main bit of analysis that we've been working on, which is an operational study. So as you heard Sujeet's talk just, the DST-PH is an evidence-based tool, and this means that there's evidence to suggest that, thank you. And this means that there's evidence to suggest that every single variable or question asked in this tool does increase the risk of avoidable death. And this based off literature views and clinical judgment. However, not all variables will pose the same risk, and we want to explore this further to see if there are any particular variables within this tool which pose a really high risk on someone dying from avoidable causes. We therefore conducted an operational study where we were aiming to determine the factors which were pushing people to be at a higher risk of avoidable death. By doing this, we hoped that we could target interventions more effectively, we can reduce the numbers of those dying from avoidable causes, and we can inform policy development with evidence. So really pushing for the evidence-based policies. So to do this, we looked at a population sample of 1,346 adults, and these were all adults, so over the age of 18, who had an intellectual disability. Everyone was open to the 4 community learning disability teams across Cheshire, Trafford and Wirral. Every single one of these adults also had a complete DST-PH conducted between 2021 and 2023. Out of the 1,346 adults, we had 24 rated red, 164 rated amber, and 1,158 rated green on the tool. These numbers associated with each of the classifications are to be as expected. The dataset contained demographic data, so this was namely gender, ethnicity, and age, and also clinical data, which was their scores for each question on the DST-PH and the overall risk classification, so red, amber, or green. We used descriptive statistics to explore demographic differences between those rating the different classifications, and a risk ratio analysis to determine the risk that specific DST-PH variables, otherwise known as the question asked, posed on being classified at a higher risk of avoidable death. So just a brief description, a risk ratio analysis, which is also known as relative risk, is the ratio of risk of an event in one group, which is typically called an exposed group, versus the risk of the event in another group, so example, a non-exposed group. Simply put, however, we use the risk ratio analysis to see which of the DST-PH questions pose the highest risk on avoidable death. So here you can see some of the demographic characteristics of the study population. Strikingly, there's an obvious lack of ethnic diversity, with 90.3% of the study population classified as white British. Other characteristics were that there were more males than females in the study population, and that the ages ranged from 18 to 87 years old. The descriptive analysis was used to see if there were any differences in the demographic characteristics of those in the study population. There were slight differences observed between those rating red, amber, and green. So, for example, there is a higher percentage of males rating red and green than females, then a higher percentage of females rating amber. Mean age increased with a higher risk of avoidable death, so as they progressed from green to amber. But these differences were limited, and so no solid conclusions on any demographic differences between those rating red, amber, and green were made. So the risk ratio analysis was performed on 4 comparisons. So we compared how each variable on the DST-PH influenced an individual's risk of rating red compared with not red, red compared with amber, red compared with green, and green compared with, amber compared with green. So on the screen, you can see the results of the red versus not red analysis. And I'll quickly explain what this graph means and what you can see. So if you look at the graph, the dot in the middle of the line resembles the risk ratio, and this is a risk that the specific variable poses on an individual rating red if they test positive for the question being asked on the DST-PH. A risk ratio of 1 indicates that there's no difference in risk. Anything greater than 1 indicates a higher risk, and anything less than 1 indicates a lower risk. Simply put, the higher the risk ratio, the greater the risk posed by that DST-PH variable on avoidable death. The lines represent the 95% confidence intervals, and if the confidence intervals span over 1, this indicates a lack of confidence in the risk ratio, as we cannot be confident in this direction of the risk. The confidence that we have placed in these risk ratios is indicated by the colour of the line. So blue represents a significant result and red indicates a non-significant result. So if we use an example here, and I'll take difficulties of posture or mobility as an example, which is the bottom line on the graph. For this comparison, someone who does have posture or mobility issues has a 30.59 times greater risk of rating red rather than amber or green, compared to someone who does not have posture or mobility issues. Because these confidence intervals do not span over 1, we can be confident that posture or mobility difficulties do increase the risk of rating red, and so this is a significant result and hence represented in blue. So our key findings from this analysis. So as you saw in the last graph, posture and mobility issues posed the greatest risk on an individual rating red rather than amber or green out of all the variables tested. And this was consistent across all comparisons made. And so this suggests that individuals with posture or mobility difficulties have a really high chance of dying from avoidable causes. So from this finding, we are advocating for an enhanced incorporation of physiotherapists within primary care settings when this is not already present. It also demonstrates that when an individual is presenting with posture and mobility difficulties, their physical health needs to be examined and really monitored quite closely. Our second main finding concerns what we did not find as significant or high risk variables, and this is namely neurodevelopment conditions, so such as autism and ADHD, availability of history or information, and cardiovascular disease. So we recognise that the exclusion of these variables as significant or high risk variables may be because they simply do not pose a high risk of avoidable death. However, this was initially quite surprising for us and doesn't seem to fit in with what other literature is saying. And so our first recommendation from this is that we re-evaluate their inclusion in the DST-PH by doing a new and more up-to-date evaluation of literature. However, there are other possible reasons why these variables are not posing a high risk of avoidable death in this analysis. And this is, for example, possibly due to a lack or a misidentification of neurodevelopment conditions or cardiovascular disease in people with intellectual disabilities. So if after the re-evaluation of these variables in the DST-PH, we still feel that they should be asked about in the tool, so if we do feel they need to be included still, we'll be advocating for an enhanced an improvement in key areas, so namely in enhancing the neurodevelopment diagnostic skills of health, social and educational professionals, and improvements in the monitoring of cardiovascular disease, so such as through the introduction of routine monitoring of electrocardiograms into the annual health check. The confidence we can place in the results and conclusions of this data analysis is reduced due to the limited size of the population. So we analysed data from 1,346 adults, which may seem quite a large number, but only 25 of these rated red on the DST-PH. So with a larger population sample, we would expect to see the confidence intervals getting smaller, and so we'd be able to place more confidence in our results. And we would also be able to account for any covariance between factors, so any relations between the questions being asked. The fact that we cannot do this, account for covariance, is a limitation of the study and something we would like to do in the future. However, it just wasn't possible in this study because of risk of overfitting because of the small population sample. We would also want to see this analysis performed on a more diverse population sample. So if you go back a couple of slides, I mentioned ethnicity, and like I said, it's a really limited ethnic diverse sample. So 90.3% of the populations were white British. And this really limits the generalizability of these results. It's known that adults with an intellectual disability who are from Black or ethnic minority groups sort of face double discrimination when it comes to accessing healthcare and are often underrepresented in research. So in the future, when the DST-PH is integrated into practice across the country, we'll make a conscious effort to ensure that the population sample is more representative of the whole population. And I think that by increasing the diversity and size of our population sample, we'll really be able to increase the confidence and the generalizability of our results. So what's next? As stated in my previous slide, one of our next tasks is to re-evaluate the inclusion of variables which were not posing a high risk unavoidable death. So we will do this by performing a more up-to-date evaluation of literature and expanding the breadth of our literature search. Another task which is currently in motion is validating this tool. And we're aiming to do this through an iterative reliability, which is where two people independently fill out the DST-PH for the same patient. Their overall risk classifications are then compared to determine if we're getting consistent results. And ideally, both professionals will be independently rating the patient in the same risk classification. And this shows that anyone with training should be able to use the tool. We're in the process of collecting this data through some training sessions which are being run across our trust. And then finally, and I mentioned this before, but in the future, we'd like to repeat this analysis on a larger and more diverse population sample. And this is to increase the confidence we can place in the results, as well as the generalizability. I don't think this will be possible for a number of years, however, and so this is a task for in the future. So yeah, that concludes my presentation. If anyone has any questions, please feel free to put them in the question and answer box and I can answer them throughout the day. Alternatively, I put my email on the first slide. So if anyone has any questions that come up after the presentation, please just email me and I can answer them as soon as I can. Thank you.
Thanks, Rosalyn. That's very helpful. We are running a little bit ahead of time, but that means we will have a bit more time for coffee break in between. But I'm going to hand it over to Danny Acton. Danny will introduce himself. And Danny has been working on DST Physical Health tool for, again, right from the beginning and has done quite a lot of work in terms of developing the training material and standard operating procedures. And he's going to talk about the practical aspects of using the decision support tool and the online resources that go with them. So over to you, Danny.
Thank you, Sujeet. So yes, as Sujeet said, my name's Danny Acton. I am a clinical nurse specialist. I am also research lead for Candid, and I am an honorary research fellow at Chester University. So what I'm really going to cover, as Sujeet said, just give you the basic of how to use the tool, some of the resources that we've created online, and obviously we're ahead of schedule, so people probably can log on and have a little look at those resources. So the tool, as Sujeet said, is split into two parts. Part one, focus on factors impacting on health outcomes. So they ask the questions, the variables, possible scores. I will go through these in more detail in a moment. And part two then looks at underlying health conditions. Sorry, Rosalyn, we turn the slide. Which then looks more about the physical health side of things, which again, I'll go through more clearly now. So next slide, Rosalyn. So part one. So first question is, what level of intellectual disability the person has? So very much scores are weighted towards the severity of people's learning disability. People with more milder learning score less, but those with more severe learning disability have a higher score rating. And this is largely based on levels of communication, being able to communicate, physical illnesses, etc. Then neurodevelopmental conditions, if the person's diagnosed or suspected as having one, then we would score that person appropriately. If a person doesn't have a diagnosis, but there is a lot of evidence suspected that there is such as autism, diagnosis is potentially there, or if they were awaiting a diagnosis, then we would score positive in that area. So also person presenting with significant behavioural problems. This is generally scored based on a person's current behavioural presentation, not necessarily based on the historic presentation. If behaviours that challenge have no impact on someone's access to healthcare, then this should be reflected in the scoring. Also someone's behaviour around actually accessing healthcare as well, does their behaviour, they don't necessarily have to have a diagnosis of challenging behaviour, for example, but their behaviour is such that you would struggle to undertake physical health observations, investigations, etc. Also, at this next section, we would look at levels about groups of medication prescribed. So depending on the group of medications. So a group of medication is defined by a specific treatment or part of a condition. For example, a person is prescribed 2 different types of neuroleptic medication for treatment of epilepsy, then this is one medication group. Also, if a person is prescribed for a heart condition, for example, 2 or 3 different medications, then this would still be one group. As required medications such as paracetamol are not included in this group of medication unless prescribed as a regular medication. So next slide, Rosalyn. So the next one is, does the person have an untreated mental health condition? Rated in this area is based on current mental health state. This is not related on mental health diagnosis. So if mental health is stable and well managed, then the person would not necessarily rate in this area. Eating disorders such as ARFID, for example, are rated in this area. Has the person recently had changes or recent transition? We all know that people working in the service, learning disability services, know that lots of information about someone does get lost when people do move or transition from children to adult services. So this is what included within the tool to reflect that. Because information about somebody is very pertinent and needed for someone's health and well-being. As also substance misuse over the last years, any issues with drugs or alcohol, and also is there historical information available? This could be from GP records, from such as people accessing the GP surgery, other health services. Has they got health action plans, and have they got health passports, etc., etc. So this is end of part 1. So if we go to the next slide, we then go to part 2. We will go on about the scoring at the end. So part 2, does the person, so this focuses on underlying health conditions. So this is about, does the person have a diagnosis of epilepsy? So a person is generally scored if they do have a diagnosis. However, if it's not, particularly if it's not well managed or the person has lots of seizures, because with advancements in treatments and medications, people do have epilepsy, but it's incredibly well managed, and they receive regular reviews, etc. And they wouldn't score. It's those people that are not as well managed we would score in this area. Does the person have a neurological condition or acquired brain injury, such as dementia, Alzheimer's disease, or is the heady brain injury? So we would score the person in this area. Does the person have a significant infection or reoccurring infections? So this area, this really focuses on people's reoccurring treatments. Is there an underlying health issue that's contributing to the people's prone to infections? So then next question would look at respiratory difficulties or conditions such as asthma or COPD. And actually, is there active treatments? Are people here to use the inhalers properly? So so we will talk about double scoring. So this is one area that we found between infections and respiratory conditions that people were generally potentially scoring doubly, because somebody may have a chest infection, for example, and they would score respiratory difficulty and an infection, because obviously it's infecting, it's causing a respiratory difficulty. So really, so we would just focus, if it's a chest infection, you would only score within the significant infection area. Then the next one is, does the person have suspected or having cancer or malignancy? So people would score obviously in this area. However, if someone is cancer free and is in remission for over 5 years, then they wouldn't score in this area. Then obviously dysphagia, or if people have had dysphagia in the past and they've got issues and care plans, for example, around their swallowing and dietary requirements, feeding requirements, the person would still score within this area. So next slide. So then about nutritional indicators, does a person have problems with their nutrition? So this is based on BMI. So there's lots of online tools available, or through health GP record summaries that can work it out for you, and it will be documented within that. So a person would score appropriately at different levels in relation to their BMIs. Does the person have gastrointestinal problems, any bowel problems? Is there any bowel management plans in place? So this would indicate levels of risk within that area, so it would score appropriately. And endocrine conditions, such as diabetes, for example, thyroid conditions, or nutritional deficiencies, or kidney disease failure, for example, would fall in this area. So one of the things people do have occasionally will come up with something that doesn't fit in any of the categories. So if there is something that someone's one of the physical health someone does have and it's not covered anywhere else in the tool, then we would score this, put that condition within this area and score appropriately. Cardiovascular conditions such as circulatory conditions, blood disorders, poorly managed blood pressure, high levels of untreated and high levels of cholesterol would score in this area. And any issues and difficulties with posture and mobility, to include feet and legs caused by fluid retention or positioning, for example. So next slide, please. So then what happens was part 1 and part 2 are scored separately. So there will be a score attached to both of these, which will indicate a red, amber or green rating. So these are then stratified. So for example, if someone scores red in part 1 and red in part 2, they're going to be red. Someone scored amber and red, amber in 1, sorry, and red in 2, for example, they would score amber. And so for example, someone scores green in part 1 and red in part 2, they would be, overall rating would be green. So next slide. So Sujeet has covered a little bit of this area, I think, it's the same slide. So we generally, the red would be seen at imminent risk of premature mortality and preventable death. Those with amber who are at high risk of premature mortality and preventable death, and those are green. There is less risk, but there still may be a risk. They may not have any physical health conditions currently, they may be younger. However, so we will really do still focus on these people to try and make sure people are going for their annual health checks, they've got health and action plans, reasonable adjustments, etc. So we'll go more into the red, ambers and greens now, and some of the ideas it's just an overview of ideas that we think people generally should try and help enhance this area. So next slide, Ros. So generally people rated as green. This is an indication that current health condition could be addressed by ensuring annual health checks, as we just covered, ensure reasonable adjustments in place. Actually, sometimes it's a good opportunity to also, if someone here does struggle to have access healthcare, is to start doing some desensitization work, get some things in place for hospital passports, liaise with liaison nurses to see if there's some flags can go on, just to highlight that the person might have difficulty if they ever access healthcare, promote the use of health passports, health action plans. Think of what type of reasonable adjustments are needed for the person to better access healthcare at home visits, etc. Can we start working towards desensitising towards potentially going to a GP practice, for example, from time to time, even different methods, different strategies. Also to ensure there is some physical health monitoring and recording tools that are used for the person, such as things that are quite commonly used within learning disability service, such as the DST, which is the Disability Distress Assessment tool. This is very good for people with more severe learning disabilities. Though definitely if it's completed by those who know people very well, they can see the subtle signs of where someone might be in distress. Things within the Northwest is very much promoted as use of the anticipatory care calendar. I know there's some other tools available, different areas of the country that use something similar. Things like annual health passports and health action plans would generally promote and start to develop those with people, would promote people to start using those. The next slide, please. So those rated as amber, the person requires more specialist intervention surrounding their physical health. So obviously a lot more consultation with the person's GP, GP practice nurse, for example, to start developing actions around specific treatment plans, what support is needed from secondary, primary care to actually help that person access their services to ensure their needs are met. Look at maybe considering health coordination, very much looking at the MDT approach and discuss the best placed professional to undertake a role in leading on actions that are needed. Start to develop person-centered plans to include all physical health actions needed. Start looking at reasonable adjustments, very much liaising with learning disability services if the person is not open, but if they are, then you would expect this to be well coordinated between primary and secondary care services. Next slide, please. So patients rated red. So again, very similar to people rated amber. However, they'll continue to have that MDT approach. Think about how we're going to help people access care, use that MDT, working relationships to develop to ensure that person's able to access the interventions and the treatments that are needed to maintain their physical health needs. So Ros, would you go back? That's it. So some of the issues and challenges of using the tool. So as we talked about before, there is occasions where people can double score. We will go on to the guidelines in a minute, but they're covered in the guidelines to try and help direct people not to double score and to direct how to score the tool correctly. There's also some information within the clinical guidelines about completing the stratification section, because this has caused problems in the past. People have become a little confused and not quite been able to follow it. So we've addressed that and thought about that ourselves. So then also there's some consistency in completing the DST when we did the initial pilot. So we thought, well, to enhance that and to include, to build on our training platform, that we created an evaluation framework that we use and encourage people to use to have regular audits of a block of people's DST-PH is completed within our electronic systems. So one of the things we have started to do recently, because one of the things that different professions have different skills and knowledge around physical health, particularly in secondary care. So our colleagues give us lots of really positive feedback. However, a lot of them actually said, what do we do when someone's rated amber or red? So we've done a lot of education and training regarding staff and types of actions they could do, how to liaise with different services to ensure someone's physical health is better managed. So I think Sujeet's covered this one, where there's some confusion between risk stratification and risk assessment, because this is a stratification tool, not an assessment tool. And there is, within the guidelines, there's very clear instructions when to review the DST. And one of the key aspects is, as Sujeet again covered, that it's not the goal of the complete theory is not necessarily to reduce the level of risk. it is to identify people at higher risk to focus interventions towards better meeting their health needs. So next slide, please, Ros. So resources to support. So one of the things we've been working on over the last 3 years is very much developing a library of different types of resources. So we have created a few versions of the tool. So there is a PDF version of the tool for people who may struggle in the early introduction of it within services to help work out the stratification. So there's an algorithm there within it that helps people use it and able to stratify the level of risk. We've used a digital version ourselves that we use within our trust, which really does help with auditing and utilising the IT, so we can start to help people within and make it more linked to clinical person's electronic patient record. We have created 2 different versions of the clinical guidelines for use. They are slightly different. They're used in primary care and secondary care. So these are all available within the website. That's at the bottom of the page. There is a very detailed training video that we have completed. It gives lots of it does lots about how to complete the tool, different challenges, some frequently asked questions. There is also a different section regarding frequently asked questions where people might have some confusion or want more clarification. So this is all available within the Candid website, which is at the bottom of the page. And I know we've finished a little bit early, so one of the purposes of that was for people to be able to log on to the Candid website, have a little look through the resources now, have a little flick through the frequently asked questions, have a look at the guides, the tool in more detail. And I think that is up to the break then, and I think we will be back.
So we are going to be back in 11:15.
So a bit 11:15. So
Yeah.
if people want to take 10-15 minutes to have a break, have a little look through those online resources, please feel free.
Hello, welcome back to the second part of today's decision support to physical health launch event. We are running slightly ahead of schedule, so we are going to change the program slightly. And I'm going to invite Sarah Pope, who is from Enfield Integrated Learning Disability Services. And she's going to talk about the pilot project they carried out using DST Physical Health in their locality. So over to you, Sarah. Sorry, Sarah, before we start, are people able to see the slides? If the slides are not moving and if it is not showing break slides, so the slide should be implementing the DST Physical Health in Enfield. If it is not moving, just log out and log back in and we will admit you straight away. Otherwise, over to you, Sarah.
Hello everyone, thank you very much for inviting me today. It's been really great to hear how the project's been developed and listening to some of the issues and the challenges and how the data's been produced has been really interesting for me today because we've been doing it ourselves. So next slide please. So my name's Sarah Pope and I am from the Enfield Integrated Learning Disability Service. We are an integrated team, so we are health and social care professionals. And we chose to implement the DST for physical health for our clients as a pilot because we were recognising the increase in health issues, particularly those health issues that were not identified during and as a result of COVID. So we've had a really good opportunity to be involved in the early stages of this. So the first thing we did was we pulled together a little project plan after meeting with the Cheshire and Wirral team. And the first thing we did as a service was identify the specific areas and pathways that we wanted to pilot this tool with. So we went with our transition cases, as we have already got a very well established team that supports the preparing for adulthood assessments, and we pick up all of our 17-year-olds at 16 and then we start assessing them at 17. So we have a really good process in place already, so it's felt like a kind of safe opportunity for us to implement this tool as part of that assessment process when the young person is moving from adult services and into moving from children's services into adult services. We also felt that the new referrals that came into the service, so these are completely new cases, so they haven't come through transition, they're not already known to the service, and they are brand new. They may be out of borough referrals, people that have moved into the area out of choice, etc. So what we wanted to do there is, as we would be doing quite a large piece of work on assessing that person as a new individual to the area, that would also be a good place and opportunity to implement this tool. We also wanted to implement it on annual reviews. I'll talk about this later, but that was another area that we decided that would be a good opportunity to have this. So the second kind of aim of the project was to ensure that all the staff had training. So we set up a series of 6 45-minute teaching face-to-face sessions, and as a requirement for booking onto those sessions you actually had to complete the watch the video that Daniel referred to earlier. Everybody came with questions and it was a really good session, so we were able to answer most of those questions. And the videos really helped the understanding, and it was a really good kind of introduction to the face-to-face teaching session as well. We ended up having to do 2 mop-up sessions and an additional 5 one-to-one sessions for the managers of the service to ensure that they really understood what the ask was. We also then set up a monthly review panel, which was to review each one of the cases, ensure that there was an identified care coordinator of most appropriate discipline, whether that be in our team or one of the primary care or secondary care services. However, that didn't go according to plan. I think people felt that they were talking too much in other areas. So we have a complex case meeting, and we also have a transition case meeting as well. So what we set up was we still went ahead with the meeting, but offered it as a monthly drop-in session. We're very lucky to have some really good service user groups in our area, and we shared the tool with them and asked them for their feedback about how they would like to have it implemented, and looked at what easy read information that they would like to have to accompany the tool. We're still kind of working on that at the moment. It wasn't, it was kind of a bit confusing, I think, because it's an assessment tool. So we're still working on perhaps how we could change some of the language or perhaps the pictures of the tool to make it into an accessible version if possible. Next slide, please. So we had some challenges to start off with. As with any new project and any new system that you want to implement, it's the change, it's the feeling of a new change, it's the feeling of the experience of change, and people who've been doing things in one way for such a long time, having that challenge and that change asked of them was uncomfortable. However, we have got over that, particularly in our transition pathway and in our new referrals pathway. What we haven't managed to completely convince are those completing the annual reviews. So we're not getting as good compliance with the project on the annual reviews, which some of it, I think, is because of the professionals that lead the annual reviews. They're not health professionals, they are social care professionals, so it is a big ask. And it's a very new area for people, but we are getting there and we are seeing improved compliance now. However, it has taken quite some time. One of the main concerns that we have from all of the professionals involved is accessing the health information on a new client. So we are lucky enough to have the Health Information Exchange implemented in our area. So we are able to access information for those who have signed up to or have agreed to be part of the Health Information Exchange. However, that's not always consistent, it's not always up to date, and it's not always available. So sometimes we just are not able to provide or have access to the information. Initially, people were really concerned about the time that it was going to take, but now we're kind of, once people are kind of used to using the tool, everyone's really consistent in the fact that generally it takes 10 to 15 minutes, providing you've got the relevant information. Staff knowledge, because we are implementing it across all of our integrated team members, some of the knowledge and the understanding of the medical terms is not as good as it would be if they were a health professional. Which is absolutely understandable. So we have been doing a lot of teaching around some of the main causes of health concern for people with learning disabilities, but that's really helped the teams understand the challenges that our clients face. And there was some confusion around the understanding of the care coordinator role. Most people didn't realise that actually what they were doing already by being involved with some of our high-risk complex cases were that they actually already were care coordinating. So once we kind of really kind of dug down and understood what that care coordinator role was, the team were happy. The challenges that we have at the moment is that not all of our GP practices in primary care, of which some of our clients would be better suited with having a primary care coordinator. They're really busy, they don't have a lead for learning disability, so that is something that we're working with the ICB on, about how we can ensure that there is a lead person for learning disability for each GP practice group. Next slide, please. So this is just some of the kind of basic data, not as eloquent as Rosalyn, but we currently have 78 clients that have had their DST completed, DST for physical health completed. Of those, only 2 were red, 9 amber and 65 were green. The 2 reds were already allocated as complex cases, so they already had somebody who could take that lead role on. The 9 ambers, we have identified issues that are consistent themes. So some of them it's obesity, some of them it's respiratory, and we are looking at setting up a respiratory health group with our local community respiratory team, and also we're working with one of our providers to set up a healthy living group that can start linking in with some of the work around health, fitness, lifestyle, etc. Next slide, please. As you can see, the most popular group is the transition age young people. We had the highest number of compliance with those, that's 38. We were also, because of the fact that we do really good reviews on our young people, the 26 to 35 were also the next highest bracket because they had planned reviews and there was already a lot of the information available to us for their completion of their DST physical health. We did have 2 70-year-olds have theirs completed on an annual review. They were 73 and 74. And it was part of kind of a reassessment of their needs due to a change through dementia. So it was really helpful to understand where they were. Next slide, please. Clients' level of learning disability. We actually had one person who actually, when we went through the record, didn't actually have a learning disability, which was quite interesting, and they were through the transition group, so it was really useful to signpost them onto the relevant service, but we found the highest proportion were the moderate, severe and profound learning disabilities. Next slide, please. And this slide just shows you the kind of the breakdown in between those with a moderate and profound learning disability and where they were on the RAG rating scale. So as you can see, those with a profound moderate were the ones that were in the red and amber groups, but they're also spread in green as well. But the majority were for mild learning disabilities were actually in the green group. So thank you. Next slide. So with the care coordinators and the care planning role, we were great with the primary care practices that have an LD lead. They're really on board, they're really supportive, and we've done lots and lots of work with them around how to use the tool, how to kind of complement the care plans that we would like to develop with the tool. And we also have in primary care a developing number of care coordinators who are really keen to take on the role for those who are amber or red RAG rated. However, what we have noticed is that probably they need some more training around learning disabilities and reasonable adjustments and the things that they are able to do to ensure that they're able to be safely managing someone's care and kind of linking in with that person. We have linked in with the acute liaison nurses at our local hospital. We haven't had anybody as yet who's kind of required care coordination from the acute liaison nurses. However, they've really supported some of the development of the care plans. Community learning disability team, health team members, obviously. We do have one social worker who's taking the lead on a complex case as their care coordinator, because they're actually they're very mild learning disability and they're accessing primary care services. We have thought about whether we need to kind of consider care coordinators being family members. We do have quite a high number of people with complex needs living at home still, but that's kind of still something that we probably need to talk about further. Next slide, please. So feedback from the tool itself, from the staff, is many of them who've been using it frequently, particularly those who are in the transition team, have said the tool's really easy to use, makes sense. Some of the feedback that we get from other members of the team is that it's really difficult to find the information, particularly if there isn't the information on their health information exchange. Already realise that they're doing the role as care coordinators, and that our complex case meeting we're discussing the more physical health cases as well as the mental health cases. As often in LD services, we focus on those that are at risk of hospital admission based on their mental health. We're actually now bringing those cases who are at risk of hospital admission because of their physical health more to our complex case meeting. Thank you. Next slide. So what are our next steps? So within the team, we've decided that the review panel isn't working in the way that it is. We need to look at either adding it into as a slot for our complex case meeting where there is a specific discussion about those who are red or amber. We also need to look at the barriers that are preventing some of our social care workers from completing the DST for physical health at their annual reviews. We're going to be doing a focused event next week to just talk through that and ask for their feedback, what they feel that they need in order to ensure that that is part of the annual review process within social care, particularly for those who don't have an identified health need or an identified health professional in the LD team. We're also linking in with the data teams at our ICB and our local authority to understand why we're having gaps in information sharing from health information exchange, as that is causing problems with finding out details in order to complete the assessment. We need to repeat training sessions. We, as probably everywhere else does, have a turnover of staff. So we've had quite a number of new staff join our team. So we need to start repeating those training sessions and looking at how we can build them into our regular training programme for staff induction or similar to our team. And we're also looking at how we can deliver some of this training to our local primary care services to ensure that they're on board. Next slide, please. Has anybody got any questions for me? I hope that was a whistle-stop tour. I think I kept to 15 minutes, but if anybody has any questions.
Thanks, Sarah. Sarah, there are a couple of questions in the question and answer box.
Okay.
So you're welcome to answer those. I have published those, so you can just reply to those questions in those boxes. But it's really helpful to listen to your pilot, because for us, our development and all that piloting process was quite organic, and you are actually kind of like, you know, importing that tool and setting it up, that process. It's really useful to hear about. Also, our services are actually mental health services, community learning disability services. You're working in an integrated service that brings its own challenges. So really helpful presentation. Thanks a lot. And if you are able to share some of those operating procedures, etc., we can put them on Candid website so that people can have access to. And I think you should definitely consider writing it up for publication so that people have access to learn from those experiences as well. So thank you very much for that.
Thank you so much, everybody. I really appreciate you giving me the opportunity to come here and also listen to you guys, because I'm sort of like thinking, how can I link in more with Rosalyn? She sounds like a fantastic resource to your team. Thank you.
Yes. So we're going to move on to the next one. I'm going to invite Beth Osbourne to talk about their pilot project in Sussex. So Beth has been a project manager for learning disability in neurodevelopmental services and carried out this project, as I understand, in the primary care. Again, we are getting that view of like a pilot in integrated service, but also piloting in a primary care service. So over to you, Beth.
Thank you, Sujeet. Good morning, everyone. Yes, I'm Beth, project manager, and I work in the LD service in Sussex Partnership Trust. So as Sujeet said, I'm going to update you on our Sussex pilot of the tool in primary care. So I'll just go through our aims and then basically the outcomes and what we'd like to do next. Next slide, please. So the aim of our project was to look at if and how the tool could be implemented into primary care systems as more of a population health tool. So we'll be able to look at the risk across that wider group of people within LD in Sussex instead of just within our specialist services, with the goal to pilot the tool in one GP practice in Brighton and Hove, East Sussex and West Sussex. And the tool was to be completed with data that's already within the GP IT system, so System 1 and EMIS Web, which are the systems that hold the patient health records. The pilot was completed by a non-clinician to look at widening the scope of professionals who can complete it to sort of help with GP capacity within the practices, so maybe admin people. And to help check this, we looked at inter-rater reliability between non-clinician and clinician outcomes. So we asked the clinicians to complete the tool against 10 health records, 10 the same records as the non-clinician, and then looking at those answers for comparison to see how similar they were. We also explored IT integration of the tool within System 1 and EMIS Web. To look at how we build templates, if it would provide the sort of automated scoring for the RAG ratings, and then developing a set of health standards for Sussex. So that's the management strategies described by Sujeet and Danny. So that's that really important bit for guidance for GPs when they get the person's RAG rating. Next slide, please. The next few slides are the results from the pilot itself, which took place over a few months. So it's data from piloting the tool across the localities, feedback from the 3 pilot clinicians, and feedback from family carers and service users who we spoke to throughout the project about the tool. Next slide, please. So this slide shows a very similar level of risk across GP practices that were used for the pilot. It is to be looked at with a bit of caution because the pilot sample was very small against the whole of Sussex, but it was still a really interesting outcome with about 75% green, 20% amber, and then 5% red across those GP practices. Next slide, please. So we're looking at the usability of the tool, and this is feedback from the clinicians who used it. All 3 clinicians agreed that it was really easy to navigate, and they also agreed that the tool's questions provide enough information to respond accurately. Next slide, please. So the clinicians were asked, do the GP IT systems provide enough information to be able to answer the tool's questions? 2 said yes, 1 said no. The no was in reference with not being able to find certain information. It was a clinician who wasn't familiar with EMIS Web, so that could just be a matter of really learning where to find that certain information to make it a lot easier. And then you'll see in the bottom speech bubble there, there's feedback that some questions are more difficult to answer than others. For example, stability of housing. So that's really to note that the pilot was completed virtually using data already on the system, so the results really reflect that information. So it is difficult to get a clear picture of maybe stability of housing or transitions information, and that might not be so accurate or difficult to judge. So to get that accuracy, to help the best of our ability, it would make sense for the tool to be completed face to face and in practice, to get that current picture of someone's physical health. Next slide, please. So tool suitability for clinical practice. We looked at usefulness of the RAG rating to support clinical decisions. On the left, you'll see there's a varied response, but this doesn't really consider the set of health standards or management strategies which were developed. So this response is to the RAG rating received by completing the tool. But of course, the RAG rating is important, but then it's what's done about that. It's that guidance that follows that's really important about the actions taken to help somebody. And table 2 is the tool useful addition to current practice in assessing people with a learning disability. And the feedback in the yellow speech bubble is for someone who had divided views. Next slide, please. This slide is looking at if a non-clinician can complete the tool. So we looked at inter-rater reliability, so that scoring comparison between the clinicians and non-clinician, to look, as I said, about that possibility of widening that scope of professionals who could complete the tool. And for this, we used a rating, so over 75% agreement on answers is considered a good outcome. So on table 1 there, inter-rater reliability, you'll see they're all over 75%, which was absolutely brilliant. Some differences in scoring were possibly due to overscoring. So there's uncertainty of severity of a condition. It's better to overscore and then go back and check and have a look so that you are always capturing people at risk rather than underscoring and missing people if they've been RAG rated as green when they should be higher. And also time lapse of scoring, because we're doing it virtually. There was the difference. People's health conditions, it changes over the time from the non-clinician completing the tool and then the clinician completing the tool. In table 2, that talks about the differences in the final risk stratification RAG rating. So Brighton and Hove is 2, West Sussex there was 1 difference, and none for East Sussex. And that chart is as the pilot was completed. So it's Brighton first, West Sussex and East Sussex. So there is a decrease in differences as the pilot progressed, possibly due to learning by the non-clinician in that sort of not having to look up medical conditions so much, you know, learning what they are, learning where to find things within the system. And then there's feedback there. The clinician noted that there will always be some sort of subjective differences in scoring. Next slide, please. So table 1 is looking at how long does it take to complete the tool. So this is looking at the average time it took to complete. The non-clinician timings are greyed out and all the clinicians are there are coloured, which shows a decrease in timings throughout the pilot for the non-clinician. Again, maybe increased learning and also, you know, getting very familiar with the system, as I said before. And the table on the right, who can complete the tool. As you can see, there's a variety of options that people are considering would be possible with training and possibly supervision. Next slide, please. So next, this is some feedback from family carers and service users from discussions throughout the pilot, because we really thought it's important to take this from being sort of a background tool that clinicians use to something that people are really aware of and can use. You know, they to have that sort of that piece of paper that would highlight their level of risk that they can take to a health professional and, you know, say, this is my level, I'm amber red, I need help and something done about it. So this is some feedback we got and it covers, so really important co-development of comms and support resources for people. So easy read about the tool, support resources, health standards, comms on what the tool is and what value it could have practically for families and service users, and using positive language. So what I need to stay well. Important to consider adapting the language. So we had feedback that RAG rating may be alarming. RAG-able was mentioned, and red also might be alarming for people. Also empowerment was mentioned a few times. So that's about you. As I said already, the outcome of the tool could be used to advocate the health needs of a service user and family. Also for managing expectations, so whether health standards are realistic and deliverable, and how to manage those expectations around this and what services can provide, and what that would mean to families and service users on receiving the RAG rating. And then finally, accessibility, to have all of those resources within some kind of digital tool, so maybe a web page that people can access really easily. Next slide, please. So the next bit is about IT integration into primary care IT systems. Next slide, please. So we're thinking about if we wanted to create a template in System 1 Animus Web. It was confirmed by Ardens, the GP-led organisation who work with primary care, to build templates, that you can build a template, automated scoring is possible. They can do data analysis with coding that's used as a reporting function, which would export into CSV format for analysis. And then to have that automated output for the RAG rating and health standards. And what also would be good is digital flagging on patient spine to alert professionals on the RAG rating risk level of premature mortality, and also thinking about that collating the data on GP practice from GP practice could also be beneficial for reporting on primary care network or PCN based level of risk for people with a learning disability, and how that then can be used to like help target focused health pathways and interventions. Next slide, please. So we also asked the pilot clinicians if they thought it was possible to combine the tool with other LD physical health checks, and their feedback was all about how they did check the LD annual health check to complete this tool, and you could maybe create some kind of enhanced annual health check. So from this, then we considered how the tool could work with the LD annual health check, as they're very similar in content about physical health. You're probably aware of what the LD annual health check is, but there's just a few bullet points there about, it's a nationally recognised health check for people with a learning disability, completed annually, ideally completed face-to-face. And then the content includes physical health check, medication, similar to the DST, and it then provides a health action plan for people to take away. Next slide, please. So we thought, well, okay, if these two physical health checks are somehow combined, what would that look like? So these are some things about, just the really good positives of that. So speedy completion of the decision support tool for physical health, as the clinicians will have all the physical health info already from going through the annual health check. Health standards and clear guidance for clinicians on pathway referral route to enhance the annual health check outcome. You have greater detail for the basis of the health action plan with the RAG rating and health standards. The decision support tool could also be a really quick physical check, health check that you can complete throughout the year if needed. It could potentially increase GP uptake of the annual health check, so adding that additional value to support clinical planning decisions. And of course, there will be a need to address uptake of the decision support tool as well, due to GP capacity, and sort of asking clinicians to complete another form. So of course, it's not just this form they're being asked to pilot and complete. There's all sorts of things going on. So combining them to create a really good enhanced annual health check and health action plan, which could then be an LD physical health toolkit. Next slide, please. So these are the next steps, our recommendations that we put forward, and how we'd really like to take this work forwards. Next slide, please. So this is our wish list. And so we'll be creating those templates in the GP systems, exploring how we could make it an LD health toolkit, combining the decision support tool and the LD annual health check. Funding, of course, is really important. So exploring sources of funding to create an extended pilot. This was our next idea across Sussex, to use a larger number of GP practices across localities, and to use the tool face-to-face and with the annual health check. So then we get that greater feedback, greater input, and then greater buy-in. Also to look at the flagging alert, so adding a digital flag, co-producing comms with family carers and service users. Of course, training people who are using the tool, using the brilliant resources that Cheshire Royal have produced. Accessibility, so developing a range of health standards and resources that are accessible for everybody. And then sharing the learning, so looking at possibly writing it up. So that's what we'd like to take forward. We haven't secured funding yet, but we are still looking. So yeah, hopefully that will happen. Next slide, please. And this is the final slide, you'll be delighted to know, which really is thinking about if it was, implemented into primary care, of all the great benefits that it would provide. And this is just a few thoughts about those future benefits, about establishing integrated care pathways for the green, amber and red cohort across services, across the system, understanding health inequalities at a population level, get that richer data about the population, benefit to service users, families and providers, by setting up clear expectations of what they should expect from health services to keep people well for longer, and benefit to NHS England to further their work on integrating the annual health check model into primary care. So that's the end of my slides. Thank you for inviting me to the launch, and thank you for listening.
Thanks, Beth. Again, this has been excellent and really helpful presentation, because we know that actually implementations have its own challenges. We are working with different systems, different processes, And I think kind of the projects and pilots like this give us ideas on potential solutions and ways forward if you want to upscale this. And you're right, I think kind of combining it with annual health checks, doing it face to face, but not using it as a standalone. It needs to be part of the system of healthcare provision.
Absolutely.
So, doing the rating is one thing, but so what? And I think that system-wide response and agreement is very important. So thank you for that. I think the service user feedback, that's really, really helpful. And we have been sort of like contemplating an idea. Is it something that we need to look at, a kind of a tool that people can sort of own? People with learning disabilities can own, and then they can take it with them. But I think we do need to think about it in a little bit more detail as to how that might be possible and how that could be done. But thank you very much, Beth, for your presentation.
Thank you.
And if there are questions in Q&A part, please have a look at. So moving on, it's my pleasure to invite Professor Umesh Chauhan. He's a professor of primary care. Umesh has been very actively involved with things all to do with physical health in people with learning disabilities. That's your area of interest. And Umesh also has been involved with the LEADER program and the part of the his academic part of the LEADER team. So over to you, Umesh.
Thanks, Sujeet. It's great to be here. It's been really interesting listening to the toolkit being used. I'm hoping to give you a little bit of a background about how the LEADER program's been working over the last 6 years. As Sujeet says, I'm a GP in East Lancashire. I'm part of the academic team that's been working on the LEADER program. I'm Professor of Primary Care at UCLan. I also work for Lancashire and South Cumbria ICB as a quality lead, and the population health kind of discussion has been really important because that's a significant role of the ICB in terms of coordinating health and social care. So Rosalyn, if you go to the next slide. So as I said, I'll give you a background about the LEADER program and update you on the changes that have occurred for in the review process, and really look at how we can avoid death, premature death, I guess, in this population group, and point out the kind of the findings from the 2021 report. Unfortunately, I'd love to have been give you the data for the 2022, but that's sitting with NHSE at the moment. So until they've approved it, I can't talk about it, and hopefully give you some more discussion points in terms of how we can move forward. Next slide, please. So I guess we're all probably here because there's over the last 20 odd years there's been a number of reports. I think you probably go back to Dame Sheila Hollins that pointed from her findings that 50% of people with learning disability died before the age of 50, and there's been a number of other seminal reports since then, including the MenCap report in 2007 and the Michael report, as well as a few harrowing findings, including the Bristol nursing home kind of reports that we've had. And we're all looking at ways to try and improve care, and I've been at this for a good 15 to 17 years in terms of looking at evaluating how the learning disability DES was implemented and the ways that we can improve annual health checks, for example, in terms of how we implement it and improve the quality of it, of that, as well as increasing the uptake. So it's worth thinking about how the letter it was introduced back and from the Sippold confidential inquiry that was undertaken, and I was part of the advisory group that oversaw that, and then the letter was introduced back in 2015, and again I was part of the advisory group that's overseen the work that Pauline Heslop and company did through Bristol University, and since then we've taken over as part of a group. So if you move to the next slide, please. That's being led by the King's College London. This is the Rogues Gallery of Folk that's taking control of that, including the partnered organisations, which includes UCLan as well as Kingston University. Next slide, please. An important part of that has been the co-production work. That's Irena Tuffrey-Winya and Richard Keegan-Bull, who has a learning disability, have been working and developing, and a significant element of that is to focus on how we convert what is fairly sometimes very dry information into accessible and easy read versions, as well as providing us with steer in terms of what we should be looking at. And they're going to be playing a significant part in the next report. I'm hoping that their voice comes through in a more meaningful way, because we're all kind of looking at ways of how we can improve the care, and that's an important element of how we move forward. Next slide, please. If you can skip to the next one, actually. So there's some key differences that we're hoping that come through for the 22 report. One of those is the fact that the publication date has been changed to October rather than over the summer, and part of that has been to allow the review process to take into account all the reviews that occur in 2021 deaths, for example. So an additional element has been the change in national policy in terms of including people who are autistic and who don't necessarily have a learning disability. So we will have a number of deaths that we've been able to look at, and we'll be able to comment on the causes of deaths, for example, and good practice and potentially areas that we can improve on. Now, unfortunately, we won't be able to provide data on under 18s in this year's report, because the process has changed in terms of how that's going to be looked at. And I think theoretically what we're looking at is having a national process for looking at all deaths for under 18s, and that includes people with learning disability, rather than being a separate entity. There will be a new chapter, as I said, around autistic people. COVID, thankfully, is less of a priority now, and so that won't be included. And overall, we're going to have a more focused reviews that provide a lot more detailed, rather than a review that covers some parts of the details. So there's some pros and cons to that, but perhaps we can discuss that in more detail. And as I said, the Staying Aligned and Well group will play a more prominent part in the report this year. Next slide, please. So, as I said, the notification element is covered by all the reports being reported or being notified, and roughly we have just over 2,000 deaths. But the initial review captures some of the data, and that includes the cause of death, for example, and ethnicity. And what we're leading to is a more focused review of deaths, and roughly we're looking at around over 200 deaths that will be looked in, potentially, hopefully 30% at some stage, that we look into more detailed in terms of what actually happened, and what are the good examples of care, and where we should be improving the care. Next slide, please. So as I said, the great emphasis on the focus reviews, some detail only collected around the initial review that we're going to lose. For example, I won't necessarily know who's had an annual health check until we do the focus review, for example, and the timing's changed. Next slide. So again, there is a focus on autistic people, and that's an important element of the change, and I think that's a really important part of how we progress and develop the quality of care that we provide the people with learning disability who had autism as well were already covered, but potentially as people recognise this, we will have a greater number of deaths that are reported, and hopefully we can improve the care as we've been trying to do through the LEADER programme for people with learning disability. Next slide, please. So the findings that what I'm going to focus on have been through the 2021 report, and we'll look at some of the data over the years as well, in terms of how things have progressed. Next slide. And this gives you an overview of the number of deaths that are typically reported since 2018, and typically we get between 200 to 300 deaths being reported. The two spikes you see are related to the pandemic, and roughly we had about 600 to 500 deaths in January 2021, for example. Next slide. One of the, I guess, if you forward to the next slide as well, has been to look at ethnicity and the potential variation now. There is a discrepancy in terms of number of reported deaths, and we've gone into that through the Race Health Observatory report that was published in July, for example, in terms of why there might be a discrepancy. But clearly, the number of deaths reported through the LEADER programme aren't a reflection of the general population in terms of prevalence, either of the ethnic minority population or potentially the number of people that have intellectual or learning disability from ethnic minorities. Next slide, please. So long-term health conditions are acquired conditions that can't be cured, but can be controlled or managed through either medication or other therapies over a number of periods of years. So we've included roughly 14 conditions as long-term conditions, comorbidities if you like, but that doesn't include learning disability or autism as one of the long-term conditions, and that's a subtle difference in terms of previous reports that have been published through the LEADER programme. And as you can see, epilepsy is a common condition that makes up almost a third of the comorbidities that exist for people with learning disability. Cardiovascular disease and mental health problems are significant as well. Next slide, please. Age at death hasn't changed significantly since the reporting up to now, but the whole point of having a population health overview is to be able to see the impact of any implementation. So theoretically, there is a large gap if people with learning disability are dying 20 to 30 years younger than the general population. There's room for improvement, and the question really for us is, what are the things we can do that can lead to improved care? And next slide, please. And if you look at it in a different way, what we're saying really here is that 61% of the people with learning disability die under the age of 65, compared to only 20% of the general population. Now that's a stark difference that we need to address. Next slide. And in terms of associations, when we've adjusted what we found that number of people who've died from minority ethnic backgrounds, there are caveats. That there is an ethnicity difference. So people from ethnic minority background die at a younger age. Place of death seems to have a difference. Long-term health conditions. So if you have an underlying condition like epilepsy, for example, you die at a younger age. And social factors, none of the social care factors that are included were associated with the age of death. Next slide, please. Common cause of death for people with learning disability over the years. Obviously, COVID was relatively new, but overall, common conditions, circulatory problems, cardiovascular disease, for example, heart attack, stroke, are a common cause of death, along with respiratory conditions and as we've said, epilepsy being a disease of the nervous system. Next slide, please. This is a slightly busy slide in terms of colours, but what in essence it shows is that there's been no real change apart from the impact of COVID over the years in terms of causes of death. Next slide, please. So avoidable mortality is what we really looked at. So what are the things that we can look at in terms of preventing or avoiding deaths? So we've standardized it, and this is something we've looked at a bit more detail. So it allows for comparison between populations, and we've looked at ages of 0 to 74 around avoidable, so it can be consistent in terms of the way we analyze data. Next slide, please. And there are certain conditions that we know that are avoidable. So infectious diseases, for example, TB, we know we've got a screening program for cancers, for cervical cancer, for example, and we know there are metabolic conditions such as diabetes that we can prevent through measures in terms of social and behaviour, as well as conditions such as hypertension that we can diagnose early and treat. Next slide, please. And what we have is a significant difference in terms of the general population and people with learning disability. So 49% of deaths we've looked at were classified as being avoidable in people with learning disability compared to the general population, which is around 22%. So in effect, there's an excess number of deaths occurring in people with learning disability compared to the general population. Next slide, please. And there are regional differences as well. And living in the Northwest, you wouldn't be surprised to know that we stick out as having a greater number of people that potentially their deaths could have been avoided through amenable ways of management. Next slide, please. So again, slightly busy slide. So that there are this overall, what we know is that that there's a difference in terms of age, in terms of cause of death, ethnicity plays a part, and regional factors also compared to London as a region. Certain areas such as the Northwest, there's a greater risk of death. Next slide, please. And just focusing on the regional differences, if you look forward to the next slide, we're looking specifically on the Northwest. Next slide. What we can show is that there's a difference in terms of deprivation. So people in the Northwest are more deprived compared to other regions. Next slide. And in terms of long-term conditions, there's a greater risk of cardiovascular problems, epilepsy, and mental health conditions as long-term conditions in the population with a learning disability in the Northwest. Next slide, please. And the top causes of death in terms of avoidable deaths were, again, COVID, pneumonia, influenza, cancer, as well as ischemic heart disease. And so potentially 53% of deaths in the Northwest were classified as being avoidable. Next slide, please. This is just, again, emphasizing where potentially there are areas that we can make an improvement in terms of avoiding death at a population level. So clearly the DST-PH toolkit is a way of looking at whether this could have an impact over time in improving and avoiding deaths in people with a learning disability. Next slide, please. Yeah, that's I guess it's the quality of care and positive practice are a really important element of being able to focus on things that are important to us. And one of the findings, and this again, this was you wouldn't be surprised to know that having a learning disability liaison nurse within a community trust seems to have a really important impact in terms of improving the quality of care being given and provided to people, and the implementation of annual health checks and action plans, as well as hospital passports, are important aspects of what we can do to improve the quality of care that we provide to people. And having a multidisciplinary approach, I think, is probably an important element that we haven't really focused on enough, because what we're dealing with is a population that requires, because of the comorbidities that exist, the importance of having people with the expertise around the different conditions being able to communicate and just provide relevant care within the community as well as a hospital setting is a really important aspect that we perhaps need to focus on a little bit more. Next slide, please. There are specific recommendations that have come out and we think are important, and there are certain things that we want to focus on a little bit more. Potentially there is an element around screening programs, and if you look at, for example, the bowel screening program that kicks in for people over the age of 55, we think potentially we should be applying this at a much younger age, perhaps looking at 40 or 45 in people with learning disability, as a way of a reasonable adjustment to try and pick up bowel cancer, because we know certain conditions such as constipation occur at a much greater prevalence in this population. There's a greater risk of bowel problems in this population group, and therefore theoretically we should be trying to pick up conditions at a much younger age. And we need to focus on avoidable mortality rather than life expectancy as a way to better identify inequalities in care. We need to look at long-term conditions, and as I say, this is where perhaps having a multidisciplinary approach would be really important for us to focus on. And again, local care pathways require improvement. How we provide vaccination programs, how we treat and manage epilepsy is really important. Next condition, slide, please. There are additional deep dives that have been conducted by the research group, and these are available on the website around diabetes, constipation, and managing care of people, of children and young people. And hopefully in the next few months we'll be publishing the pneumonia and epilepsy guides as well. Just the final slides are just to say a big thank you to all the contributors to the report, and if you do have any further questions, hopefully I've left enough time for us to do that. Thank you.
Thanks, Umesh. It's really informative, really helpful presentation. And I think kind of looking at the Northwest in the context of national picture is also really helpful. And I think that will nicely actually go into the next presentation where, as you're aware, as an operational delivery network, we have a physical health work stream, and we are looking at actually finding our regional solutions when it comes to the physical health of people with intellectual disabilities. In terms of question and answers, we'll have some time afterwards, so we're just going to have one more presentation. But in the meantime, do put your questions in the Q&A box, and we can answer them straight away, or we can then actually use them for our Q&A session afterwards. So thank you, Umesh. I'm going to move on to Professor Mahesh Odiyoor. He's going to talk about the physical health work stream that has been set up as part of Northwest Learning Disability and Autism Operational Delivery Network. So over to you, Mahesh.
Thanks, Sujeet. So as was mentioned, this is going to be a brief introduction to the operational delivery network, what it means, but also a little bit about the physical health work stream and what we want to achieve in collaboration with all partners in the Northwest region. Next slide, please. So operational delivery network, or ODN, it is a network of 3 transforming care partnerships in the Northwest region, and it has been set up as a way of enhancing the quality of care delivery, reducing inequity, and improving the access, and doing that through collaboration and enhancing patient pathways. So rather than try and do in our little different silos, the aim is trying to see whether we can collaborate with, whether we can understand good practice in the Northwest region and try and apply it across the board. So when I talk about 3 transforming care partnerships, the 3 of them are Cheshire and Merseyside, Greater Manchester, and Lancashire and South Cumbria. So the aim of the network is also to look at some strategic decisions and priority setting, and it is not a body that enforces or sort of has a commissioning responsibility or anything of that sort. All that it does is it looks at good practice, makes some recommendation that organizations could consider, and then support and collaborate in developing that and embedding that across the Northwest region. And the aim of that is to deliver a whole system improvement at all levels of care in the Northwest region. And that would be through effective clinical leadership at every level and through collaboration. So that's the aim and ambition of the operational delivery network. Next slide, please. Little bit of the structure. As I said, it was established in 2017. The ODN was the first of its kind in the country. It was a pilot. It was a way of seeing whether the transforming care program can be taken to that next level where the different transforming care programs could work together and link together. So we were the first one in 2017, and as I said, it covers the whole of Northwest and 3 transforming care partnerships: Cheshire, Merseyside, Greater Manchester, and Lancashire, South Cumbria. Following us, Northeast developed their ODN, as well as Yorkshire and Humber developed their ODN as well. So there are 3 operational delivery networks all covering the north of England, and there is no similar structure in the south of England. And in terms of the structure, again, it is as you can see, the chair is Marian Elligan, Director of Nursing at Greater Manchester GMMH. I'm the clinical lead and deputy chair, and we have a project manager, and we have at the moment 4 main work streams. We also used to have the work stream for dynamic support database that quite a lot of you will be familiar with, and that was about establishing that and embedding that. On the successful completion of that was taken off as a formal work stream. There is a request now that it might come back on stream for other purposes, but the other ones that we have are children and young people, autism work stream, physical health work stream, and the complex continuing care work stream, or the rehabilitation work stream, and they are led by the people mentioned there. The physical health work stream is led by Michelle Sowden. She's from the NHS England Northwest, and she takes the lead on the physical health work stream. And we have a collaborative group of people, including GPs, primary care representatives, secondary care representatives, as well as other health organizations in the region. So it's a collaborative approach to try and see whether we can find some solutions to some long-standing issues and problems. Next slide, please. So the purpose of the physical health work stream is to support the development of a Northwest-wide program to address the health inequalities. And Umesh very nicely set out some of the challenges that we face. The LEADER program has been highlighting some of those challenges year on year, and particularly in the Northwest, there are some stark challenges that we face. And the aim of this work stream is to say, could we find some solutions? Or if there are already existing solutions, could we scale them up across the Northwest region and get better outcomes? The work stream will be drawing on learning from the LEADER reports, but also the Stomp Stamp agenda, as well as the annual health check program. So if there are themes, data, information, we want to draw on that and then develop a model of care. And the aim of the work stream is to enhance the health equity, improve the monitoring aspects, and then management of the deteriorating health in people with intellectual disability, with or without a neurodevelopmental disorder, and achieve better health outcomes. Next slide, please. So some key objectives. One is to develop a shared understanding of a range of activities that take place in the Northwest region, and that is health promotion activities, health improving activities, specific strategies to address health, physical health needs, and so on. Second one was to agree and pilot a regional health stratification process to improve the access to healthcare. And so the DST, the decision support tool for physical health is very important example of that stratification process, but there may be others. So we are exploring that and then seeing how best to embed that in the Northwest. Then agree physical health priorities for action and support the development of an associated quality standards to improve the consistency of support. So the aim is that once we do that exercise, there will be themes that are generated for which we can develop sustainable pathways and quality standards. Agree a model of care that covers primary, secondary, and tertiary care. And this is the next ambition. So next set of ambition, as in once you understand the problem, once you stratify the needs, there's always a big question, so what? So if you identify somebody is red, if you identify somebody is amber, what are we going to do? So if you take the challenging behavior mental health side of things, an example is the DST tool. When we use the dynamic support database tool to identify people who are red and amber, then we provide additional support in using our intensive support services, trying to avoid unnecessary hospital admission, but also provide better care in the community. So the question is, do we need to think something similar for physical health? But again, this is a theoretical model at the moment. We may need to develop that thinking a bit further. We also need to look at identifying opportunities for specialist role development across primary, secondary, and tertiary care. And this is around specialist around physical health needs. And they could be in a multidisciplinary way, not just doctors and nurses, but also other specialist roles, including community pharmacists and so on. So again, thinking about what are those key roles that we need in order to deliver a better quality of care. And finally, it is about enhancing the collection of relevant data. So we have a LEADER data as one data point, but are there other relevant data, population-based health data that we can gather, we can then use to answer the questions and develop and tweak further the numbers from 1 to 5? Could we look at data in a different way? Again, this is a way that we want to use this workstream to see if there are any other better ways of doing this thing in the Northwest region. Next slide, please. So what have we done so far? So in terms of understanding developing a shared understanding, we have started a mapping exercise. We have started a process of understanding what are all the different practices in the Northwest region, which is currently enhancing and improving physical health care for people with ID and DD. So we hope to do that over the next few months, and then hopefully we'll have a picture of the Northwest with some areas or the clear idea of what's happening in the different areas. The next one is to develop that pilot for needs stratification. A task and finish group has been established, and they will have a rotating chair. The first chair will be Lisa De Nicola, and the aim is not just to say, oh, we have the DST physical health tool, we are going to apply that, but we are going to use that as one of the tools. We will look at, are there any other stratification tools that can be utilized, and then agree a model of stratification, which we can then start piloting in small areas and then hopefully expanding, very similar to how the dynamic support database clinical support tool was established across the Northwest. There are other ways of doing that, but this will be discussed in that task and finish group. And then final one is that we are looking at options for data, improving the data collection to see whether there are any other currently usable systems in the Northwest that we can sort of piggyback on. If not, are there other ways of trying to do that in an innovative way? Next slide, please. Following that, once we have those things, we will collate all, as I said, once we identify the good practice, we'll collate and map that and then share that with relevant people across the Northwest. We will embed the stratification process once we agree on that in the task and finish group. We will agree develop an agreed system to gather and analyze the relevant data. What we then want to do is start identifying gaps. So what are the gaps in delivery of care in the Northwest region, whether it's in the primary care system, secondary care, or tertiary care? By understanding that, we then want to develop a model of care. And hopefully we can then draw in some additional resources to support people with significant physical health needs or barriers to access healthcare. Now, there may be already existing resources which might be used in different ways. The aim is that if we develop a model of care, can we then harness some of those existing resources in a consistent way, but also then can we put in some bids for some additional resources to meet the needs of people with ID, NDD in the Northwest region. We also then aim to develop a larger network for sharing information. Either we develop we already have the ODN, but can we enhance that further, particularly around the physical health work stream, to develop a network of organizations, people, services, both for sharing information, but also sharing good practice as well. So these are some of the aspirations in terms of next steps. Next slide, please. So finally, in terms of aspirations, aspiration is to, I always put this picture because that probably conveys more than what I can convey in terms of words. What we aim for is inclusion for all our service users who access services. This is people with intellectual disability and neurodevelopmental disorders. But we want to do that, and we want to improve the equity of care. We want to look at personalization of care, which should then lead to inclusion. We want to look at better systemic planning. At the moment, there are some great practices that take place, but they seem to happen in pockets. Could we do that in a much more systemic way, much more organized way, so that we can share that practice across the Northwest? And by doing all that, the final aim is to improve and achieve better population health. As Umesh very clearly highlighted, the needs in this population group is significant. There is a significant gap between life expectancy. There is a significant gap in terms of life, in terms of outcomes of care, in terms of quality of life. We really want to achieve an improvement in all of that at a population level. So that's the main aspiration of all these pieces of work. Next slide, please. And that's it. Thank you very much. And if there are any questions, we can share that as part of the bigger question and answer. Back to you, Sujeet and team. Thank you.
Thanks, Mahesh, for that overview. As you can see, there are lots of actually initiatives that have been taking place, and not just in Northwest, it's everywhere really, isn't it? And we all are working towards that one sort of towards an objective. And I think it would be great to collaborate. It would be great to communicate. It would be great to regularly come together, share, learn from each other, but also actually cross-purpose and develop some projects and pilots going forward. So we had quite a few interesting presentations. We talked about the DST physical health development and what we have been doing here, its conceptualization, its piloting. We had very interesting presentations from Sarah and from Beth about their experiences process of importing this tool in their services and implementing. I have certainly learned from those 2 pilots because it has given me ideas as to where we might be going wrong or where we might be able to do things differently. And I'm sure it will be a useful learning for the ODN physical health workstream as well. Again, Umesh's data has been really helpful. So it all nicely comes together. We do have some time for question and answers. And I know there were some questions in the chat box, not in the chat box, in the question answer box. They all have been answered. But if there are any questions that people would like to ask to any of the presenters, you can either put your hand up or you can put it in the box. Rosalyn, you might want to actually take the slide down, and we can have it as a screen where we can see everyone.
Hi, Sujeet. There was actually a couple of questions in the question and answer box which haven't been answered yet.
Okay.
So there's one from the beginning of the event asking about whether you considered the impact of chronic ear infection as a variable on the DST-PH. I think she was particularly interested in those with perforations, and if this has been of consideration during development.
So hearing impairment and visual impairment, these were the things that were brought up. We had not included them in as factors in DST physical health at that stage. And this all came out of the Delphi groups as well. And one can actually understand the impact of those 2 factors, the visual impairment and hearing impairment that might have had on access to accessing health services. So we do need to consider that. And again, I think some of this improvement and adaptation of the tool is going to be dependent on as we pilot them to wider and wider population and as data becomes available. So it's not just including the factor, we need to actually then look at how the weighted scores will look like and how the overall impact will be. So all that feedback that comes through pilot, through comments, etc., we do collate that with the idea of improving the tool going forward. For example, there was also a question about Black and ethnic minority groups. Now, when we set up initially the project to develop the tool, that had not come through as an important variable either through literature or through focus group. But we now know through the later reports and inquiries that it is becoming an important factor. So this is something that we do need to take into account. So like any tool, we will have to continue to improve it going forward by considering all those factors.
Thank you. There's also one other question from Abby Lonsdale, who has asked if there's any thoughts about working alongside LD all age continuing care when undertaking a DST, and all working alongside people eligible for those services during the annual health checks and annual reviews.
Yeah, I think that absolutely makes sense, and I think what we don't want to be is prescriptive as to where and how it could be used. And as I said in my slide, that it can be used by any professionals working with people with intellectual disabilities. As long as actually they had the training, they know how to use the tool, that's absolutely fine. I think combining it with annual health check will be fantastic. It is meant to be a population health management tool, so it needs to be used at the population level. So if anyone who is going through the annual health checks has DST physical health done along with it, absolutely fantastic. If it is used in primary care, then that can be almost becomes part of that person's health passport. It also becomes part of then of joint assessment of needs and other things as well. Yes, there is no particular kind of restriction on where it could be used or not used. Use it, develop your own standard operating procedures. If you have any learnings from your use, any comments, any suggestions for improvement, do get in touch with us through Candid website, and we will continue to work on improving the tool. Any other questions, comments? If that's the case, well, thank you very much for joining today. It has been a very helpful exercise from our point of view. I hope you all found it useful, that you all look at our Candid website for the resources on DST physical health. If you need any help with implementation, you know people whom you can approach and go to, do get in touch, and do keep us informed of your experiences. So thank you very much.